Synovial sarcoma is an oncological disease. Look at this picture, knee joint and findings. Look at this X-ray findings. Detail going on. Introduction. Synovial sarcoma is a rare and aggressive type of soft tissue cancer that most often affects adolescents and young adults. Despite its name, it does not arise directly from synovial tissue, but rather from multipotent mesenchymal cells. It commonly occurs near large joints of the arms or legs, but can develop in any part of the body. Early detection and multimodal treatment are essential for improving outcomes. Definition. Synovial sarcoma is a malignant soft tissue tumor characterized by chromosomal translocation TX18, P11, Q11, resulting in the SS18SSX fusion gene. It typically arises in deep soft tissues, particularly near joints, tendons, and bursa. Etymology. The term synovial sarcoma was coined because early clinicians believed it originated from synovial cells of joint linings. Later research found that it arises from primitive mesenchymal cells that only resemble synovial tissue under the microscope. Epidemiology accounts for 5 to 10% of all soft tissue sarcomas, more common in adolescents and young adults 10 to 40 years. Slight male predominance typically affects extremities around the knee, most common. Rare in the elderly and very rare in children under 10. Types. Synovial sarcoma is classified based on histology. 1. Monophasic, composed mainly of spindle cells. 2. Biphasic, contains both spindle cells and epithelial components. 3. Poorly differentiated, high grade, aggressive variant with small round cells. Causes. The exact cause is unknown, but the disease is primarily linked to genetic mutation, not inherited but acquired. Chromosomal translocation TX18 producing the SS18SSX fusion gene, which drives abnormal cell growth. Risk factors. 1. Age, commonly 10 to 40 years. 2. Male sex. 3. History of radiation exposure, rare association. 4. No strong evidence of environmental or lifestyle related risk factors. Complications. 1. Local recurrence. 2. Distant metastasis, commonly to lungs, lymph nodes, bone. 3. Functional impairment of affected limb. 4. Chronic pain. 5. Post treatment complications, example fibrosis, neuropathy, lymphedema. Pathophysiology. Here is clear step-by-step pathophysiology of synovial sarcoma written in the simple logical sequence for easy understanding and study. Pathophysiology of synovial sarcoma step-by-step process. Step 1. Genetic mutation occurs. A chromosomal translocation happens within a single mesenchymal primitive or connective tissue cells. The specific translocation is TX18, P11, Q11. This causes two genes to fuse, SS18 on chromosome 18, SSX1, SSX2, SSX4 on chromosome X. Step 2. Formation of the SS18 SSX fusion gene. The chromosomal break and rejoining create a new hydroid gene. The fusion gene proceeds an abnormal SS18 SSX fusion protein. This fusion protein is the key driver of synovial sarcoma. Step 3. Abnormal transcription regulation. The SS18 SSX fusion protein enters the cell's nucleus. It attaches to SWI, SNF, BIF chromatic remodeling complexes which control how DNA is read. The fusion portion disrupts normal chromatin remodeling, suppresses tumor suppressor genes. Step 4. Dysregulated gene expression. The abnormal fusion protein altered gene expression patterns. Promotes cell proliferation. Inhibits cell differentiation. Blocks apoptosis. Programmed cell death. Stimulates angiogenesis, new blood vessel growth. This leads to gradual transformation of the one normal precursor cell into cancerous synovial sarcoma cell. Step 5, clonal expansion of tumor cells. The transformed cells begins to divide uncontrollably. Each new cancer cell carries the same SS18 SSX fusion. A microtumor begins forming in deep soft tissue, usually near joints. Step 6, tumor microenvironment changes. Cancer cells release signals that attract inflammatory cells, promote blood vessel formation, remodel the extracellular matrix. This allows the tumor to grow aggressively. Step 7, development of histologic subtypes. Depending on how cells differentiate and proliferate, the tumor may appear as monophasic, mostly spindle cells, biphasic, spindle plus epithelial cells, poorly differentiated, high grade, aggressive. This variation reflects the disrupted developmental pathways caused by fusion protein. Step 8, local tissue inversion. The growing tumor begins to compress nearby muscles, nerves, or vessels. Erode surrounding connective tissue, cause swelling, pain, or loss of mobility. The tumor often appears well circumscribed on imaging but is microscopically infiltrative. Step 9, angioinversion and metastasis. Tumor cells invade small blood vessels. Synovial sarcoma commonly spreads via bloodstream. Most frequent metastatic sites lung, lymph nodes, bone. Metastatic occurs partly because the fusion protein enhances cell migration and survival. Step 10, tumor progression and clinical symptoms. As the tumor enlarges, it leads to a slow growing mass, pain from nerve or tissue compression, decreased joint mobility, late stage systemic symptoms, fatigue, weight loss. In summary, the process is one line: genetic translocation, SS18 SSX fusion, abnormal transcription, malignant transformation, tumor growth, inversion, and metastasis. Stages. Stages is done using the AJCC TNM system. 1. Stage 1, low grade tumor, no metastasis. Stage 2, high grade tumor, small size. 3. Stage 3, high grade, large size or node involvement. 4. Stage 4, distant metastasis, lung, bone, lymph nodes. Signs and symptoms. 1. Slowly growing, painless mass near a joint. 2. Pain or tenderness, late symptom. 3. Swelling or stiffness in nearby joint. 4. Numbness or tingling if nerve are compressed. 5. Decreased range of motion. 6. In advanced case, weight loss, fatigue, breathing difficulty. Diagnosis. Diagnosis includes 1. History and physical exam. 2. Imaging, MRI best for soft tissue. CT chest to check metastasis. PET scan optional. 3. Biopsy, core needles. Biopsy for histology. 4. Genetic testing. Identification of SS18 SSX fusion gene confirms diagnosis. Nursing diagnosis. Possible nursing diagnosis including 1. Acute or chronic pain related to tumor growth. 2. Impaired physical mobility related to tumor location or treatment. 3. Risk for infection related to chemotherapy or surgery. 4. Anxiety related to cancer diagnosis. 5. Deficient knowledge regarding disease and treatment. Management. 1. Surgery, primary treatment, wide local excision. 2. Radiation therapy, pre or post operative to reduce recurrence. 3. Chemotherapy agents, doxorubicin, ifosfamide, used for advanced or metastatic disease. 4. Targeted therapy, drug targeting fusion proteins under research. 5. Immunotherapy, limited but emerging role. Nursing management. 1. Pain assessment and management. 2. Monitoring for chemotherapy adverse effects, nausea, neutropenia, nephrotoxicity. 3. Wound care after surgery. 4. Encouraging mobility and range of motion exercises. 5. Providing psychological support. 6. Educating patient and family about treatment and follow-up care. 7. Monitoring for complications, infection, lymphedema. Treatment options. 1. Surgical excision. 2. Pre or post operative radiotherapy. 3. Chemotherapy. Infosfamide plus doxorubicin. 4. Targeted therapies, clinical trials. 5. Immunotherapy, experimental. 6. Palliative care for advanced stages. Psychosocial medicine. 1. Counseling and emotional support to cope with cancer diagnosis. 2. Support groups for patients and families. 3. Stress management techniques, meditation, relaxation, mindfulness. 4. Education and communication to reduce fear and uncertainty. 5. Vocational and rehabilitation support to help return to work or school. Prevention. There are no known preventive measures because the tumor arises from spontaneous genetic mutations. However, one avoid unnecessary radiation exposure. 2. Maintain routine medical checkups for early detection. 3. Seek prompt evaluation of any unusual lymph or swelling. In conclusion, synovial sarcoma is a rare but aggressive soft tissue cancer commonly affecting young individuals. Early recognition and a multimodal treatment approach, including surgery, radiotherapy, and chemotherapy, are crucial for improving prognosis. Ongoing research into targeted therapies and immunotherapy offer hope to better outcomes. Comprehensive nursing care and psychosocial support play a vital role in the patient's overall quality of life. Thank you. Have a nice day.